Merhaba arkadaşlar.
Good evening, everyone, distinguished friends, distinguished colleagues. I'm going to talk about something which has been neglected for a very long time. As you know, the rate of mental retardation among the population is 3% on average, but it doesn't get the required attention, and especially in terms of psychopharmacological treatment. I will talk about this a little bit. During my residency, I had the chance to work for the inpatient unit, and I'm going to talk about my experience from there. The word intelligence means a spark in the mind in Arabic. It means the mental skill to find new adaptive solutions. Of course, this is one of the most important things which differentiate human beings from animals. The mental retardation ratio among the population is between 1 to 3%. Mental retardation is going to be our framework here. I'm going to talk about what we see in that patient group, what are the COVID conditions. We first have to make the diagnosis so that pharmacological treatment can be given. Mental retardations, 85% is mild, 10% is moderate, 3 to 4% is severe, and idiopathic is 1 to 2%. IQ is usually before 70 in that group of people. Environmental and educational support, when this is missing, the minimum level threshold of IQ can go up to 75, 78, and this increases or doubles the incidence. This is really important, especially the borderline intelligence group that we're talking about should get a good education, otherwise the prognosis might be really bad. The causes are prenatal or genetic disorders like Down syndrome, Williams-Prader-Willis syndrome, or it might be a familial retardation. The parent might have mental retardation. The maternal infections are another problem. Syphilis, HIV, toxins, maternal alcohol use causes mental retardation. Prematurity, low birth weight, especially if the child is below 1,500 kilograms, the risk is even higher. Oxygen in the womb is important. If there is a problem in that sense, the brain growth is negatively affected. Perinatal causes are like 10%. The infections, meningitis, encephalitis, neonatal asphyxia, bilirubemia. Postnatal causes are like infections and psychosocial deprivants. If phenylketonuria is not treated, the rate of mental retardation increases. Epilepsy, and sometimes you cannot find any reason, any cause. You see that the parents have a good intelligence and there is no disease, but still you might see the rate among those people really high. They start with retardation or slowing down in speech, walking, forgetfulness, failure in classes, and poor communication or playing with children who are not their peers. Children and adults with mental retardation have higher incidence of comorbid psychiatric disorders. Comorbid psychiatric disorders among those children is between 30–60%. They are usually attention deficit disorder, anxiety, mood disorder, impulse control disorder, behavioral disorder, psychosis, schizophrenia, Tourette and enuresis, encopresis, and sleep disorder. And according to their peers, they have a 3 to 4% more of a depression risk. People with mental retardation obviously cannot protect themselves like normal human beings. This is the reason why they are subject to child abuse, stigmatization, bad behavior by peers, and exclusion most of the time. In children and adolescents with mental retardation, comorbid psychiatric disorders are usually skipped. The most important reason for that is stigmatization. We just call it MR and we do not say anything else because we believe that after this diagnosis the other things are not that important. So we miss or neglect most of the things. Unfortunately, this is the case. As the mental retardation becomes severer, comorbid psychiatric diagnosis becomes more difficult. Distractive behavioral disorder, aggression and self-injury is what we see more during treatment in that patient group. Mild mental retardation has more comorbid diagnoses like depression and anxiety disorder, etc. Of course, ruling out the causes which might cause mental retardation are very important. I mean, marriage among relatives should be prevented and immunity should be strengthened in children. Metabolic problems like phenylketonuria should be treated, and epilepsy treatment is also important. Education, familial and environmental support are also important. This is very, very important, familial and environmental support. And for whom do we consider psychopharmacological treatment? For those who have aggressive behaviors, depression, anxiety, psychosis, which drugs do we prefer? I'm going to talk about those in a few minutes in a more detailed manner. Psychostimulants, antidepressants, anticonvulsives, antipsychotics are the drugs that we use the most. Adaptive behaviors become more difficult, so serious behavioral disorders are seen more among those who are mentally retarded. Antipsychotics are the first treatment that we give in people with aggressive disorders. Antipsychotics, atypical antipsychotics are our first preference. Risperidone, olanzapine, quetiapine, aripiprazole, clozapine, risperidone are preferred the most. And as I said before, unfortunately, we have very little studies on people with or children with mental retardation. Risperidone is the first choice for those children with aggressive behavior. Atypical antipsychotics have certain adverse effects like weight gain, serum lipid changes, diabetes development, cardiological adverse effects, increase in prolactin, sedation, and sexual dysfunction. In a study with risperidone, sedation and weight gain were found to be the most important side effects. Adolescents and childhood are our first groups of preference for risperidone. In addition to what I just talked about, it might contribute to anxiety as well. Unfortunately, many of the doctors might neglect this. If the oral administration is not regular in the patients, depots can be preferred to antipsychotics. Risperidone constants might be preferred, and unfortunately it is 25 milligrams among adolescents, but psychopharmacological treatment that we give to adolescents is not different from that we give to the adults. Quetiapine is safe among those who have dystonia risk. We use it more among adolescents. Depression, aggression, irritability, and suicidal tendencies in children and adolescents might also require the administration of this specific drug. Aripiprazole is the most reliable antipsychotic among those with metabolic syndrome risk. And not enough trials in the field of mental retardation, but the trials conducted have given positive results until now. Olanzapine has a strong efficacy, and metabolic syndrome is an adverse effect. Clozapine is what we prefer in resistant cases. We want the patient to be hospitalized for this. The blood values are closely monitored, and what is metabolic syndrome? Metabolic syndrome requires the presence of at least three of the criteria among the 5 mentioned below, like central obesity, abnormal triglyceride levels, abnormal high-density lipoprotein levels, abnormal blood pressure, abnormal blood sugar levels. Ziprasidone and studies with ziprasidone are unfortunately negative. Dystonia is a risk, especially among the adolescents. Cardiological adverse effects might be seen, so we do not prefer it a lot among adolescents. Typical antipsychotics like chlorpromazine might be used. Neurodol might be used. Of course, from a cardiological perspective, chlorpromazine requires a close monitoring. The mood stabilizers are helpful in aggressive behaviors. MR studies are not enough again. Combined treatments might require the use of those valproic acid, polycystic ovarian syndrome might be an adverse effect. Lamotrigine might be required. Stimulant drugs are preferred if the MR is mild. As the MR advances, stimulating drugs cause more aggressiveness. Methylphenidate is the one that is used the most, and combined treatment with antipsychotics might also require this. Atomoxetine, I used this in patients with Down syndrome a couple of times. If there is destructive behavioral disorder, then this weight gain adverse effect of the antidepressants might be avoided. Of course, it causes aggression. These stimulating drugs are not advantages in all patients with MR. On the contrary, you might see aggressive aggression. The lack of appetite is a disadvantage, but it also might turn into an advantage because those with MR might put on weight. When do we use the antidepressants? In depressive cases, in repetitive behaviors, anxiety and social phobia, behavioral activation among MR individuals require low-dose administration at the baseline. Children with MR are more prone to anxiety disorder and fear. Therefore, we shouldn't skip this as well because I believe it is also important. Introvertness, lack of self-confidence. Benzodiazepines are usually preferred when there is a severe aggression. Opioid antagonists, naltrexone is used, especially if there are repetitive behaviors which are self-destructive. This one is found to be very helpful. Hormonal drugs, especially if there is sexual aggression, which is resistant to treatment, might require hormonal treatment. In many of the patients, in many of the families, you do not get the required answer if you do not ask it for yourself, because testosterone level is high at the level of adolescents. Suddenly 10 times more of an increase is seen, and even an adolescent with a normal IQ may not know how to control this. So sexual misuse cases increase at the level of adolescents. When there is mental retardation together with that, you actually talk about a mental problem, not a hormonal problem. Splitenate acetate is used. Antrocure 50 and 100 milligrams are used most of the time. I had 3 to 4 cases, and I got very good results in those. Antipsychotics were given or antidepressants were given to those patients, but they couldn't prevent the problem. This is really important. When a guest comes, the child might masturbate when the guest is there, or there might be those doing it outside, or sometimes there might be certain harassments towards the sister or the mother, and unfortunately, one of my patients had to be locked in a room before the mother went to sleep. Antipsychotics and psychostimulant drugs, drug combination therapy in attention deficits is used really frequently. And about the combinations for MR patients, we need to have more trials. Symptom clusters and adverse effect profiles should be taken into account during the treatment. Risperidone, quetiapine, risperidone, olanzapine, quetiapine might be used, or aripiprazole specifically for the patients who are overweight might be preferred, because we give risperidone and cannot get a good response. If the patient is overweight, the dosage does not necessarily have to be increased. Aripiprazole can be added to the existing regimen. In aggressive behaviors, which is resistant to treatment, mood stabilizers can be added to antipsychotic agents. And let me give you a case, and then I'm going to be showing you the video. This is a child, 15-year-old boy, severe MR and autism, destructive behavior, and pinching, punching, squeezing, and 3 to 4 times severe aggression seizures in a week. Olanzapine was given in the beginning, 15 milligrams, quetiapine 300 milligrams, and valproic acid 1,000 milligrams. Let me show you the video, and then maybe we can discuss it.
de zarar veriyor. Yani kapattık mı? Tamam. Sıkıyor. Özellikle Bazen nöbetler çok ciddi oluyor. Enjeksiyon yapmak zorunda kalıyoruz. İşte noradollergaktil veya işte klopiksel aktifaz gibi. Babası 8-10 saat nöbetlerin sürdüğünü söylüyor evde. Maalesef baş edemiyorlar. Kırıp döküyor. Sürekli zaten herhalde bir eliyle sabit bir yere bağlı bir şekilde duruyor çocuk.
Çekelim.
Kendi kendine kapanıyor. Şunu büyütebilir miyiz acaba? Annesi ev hanımı, depresyon ve konversif bayılmaları var. Hayattan hiçbir beklentisi olmadığını belirtiyor. Yani baba fabrika işçisi olarak çalışıyor. Ancak çocuk yüzünden maalesef işi bırakmak zorunda kalmış. Çünkü anne baş edemiyor tek başına. Peki neyle geçiniyorsunuz diye sordum. Yani özürlülük maaşı ve komşu ve akrabalardan gelen yardımlarla geçiniyorlar. Yani bunu söylememin sebebi arkadaşlar, özellikle bu ağır MR hastalara biraz daha hani şefkatli yaklaşmamız gerekiyor. Yani gerçekten çok zor. Hani bir depresif ergen geldi diyelim veya bir anksiyete bozukluğu. Onlardan biraz daha bence toleranslı davranmamız lazım. Hepimiz hekimiz. Gerçekten çok hasta görünce bazen kendimizi kaybedebiliyoruz. Ama bu hastalara bence biraz daha, çünkü toleranslı yaklaşmamız lazım. Çok zor hastalar. Yani anneyi babayı maalesef kilitliyorlar eve. Hasta yaklaşık 2 ay kadar yattı. Yatış sırasında gözlemlerimiz biraz önce işte kendini yere atıyor, duvara yumruk vuruyor. Refakatli olarak babasının kollarına takıntı şeklinde sıkıyor. Yine hastane personelinin zarar veriyor. Yemek yemeyi zaman zaman reddediyor. Sebepsiz ağlama ve gülme atakları var. EG çekelim dedik fakat maalesef başarısız olduk. Ciddi öfke nöbetleri var. Lafı fazla uzatmayacağım. Bu hastaya en son olanzapin 20 mg verdik. İşte risperdal consta 25, valproik asit düzeyini arttırdık. Diazem verdik. Bu hasta özellikle diazemden fayda gördü. Bu öfke nöbetleri haftada 3-4 kez vardı. Babasıyla en son görüştüğümüzde ayda 1'e düştü dedi. Yani zaten hasta çevresine ve kendine zarar veriyor. Fakat bunlar bazen nöbet şeklinde çok ciddi oluyordu. Bu nöbetler sıklığı azaldı. Anneyi yatış sırasında psikiyatrik tedavi yönlendirdik. Kriz sayısı nadirleşti. Bunu da ek olarak koydum. Mesela 6 yaşında hafif MR artı ADHD tanısıyla takip ettiğimiz hasta. Bu başka bir olgu. Başvuruyor bize. Risperdal kullanıyor. Annesi hala agresif davranışların devam ettiğini söylüyor. Ayrıca ağzından salyalar akıyor. Tedavide ne gibi yol izliyoruz? Antipsikotik dozu daha da arttırırsak ekstra piramidal semptomlar olabilir. Muhtemelen ağzından salya gelmesi ekstra piramidal semptomlarla alakalı. Kolinerjik yapıyla. O yüzden bu hastaya mesela valproik asit kombinasyonu deneyebiliriz. Yine kısa etkili mesilfenidat başlarız. Onu deneyebiliriz. Salya akmasına yönelik antihistaminik tedavi verebiliriz. Teşekkür ederim.